I am Dr. Hassan, and today I will tell you about latest update in hypertension. As per WHO, nearly 63% of total deaths in India are due to non-communicable disease, of which 27% are attributed to CVD, which affect 45% people in the 40 to 69 age group. Raised blood pressure is among the most important risk factor for the CVD. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively, as per WHO. Despite that, nearly half of the people are 51% of the men and 41% of women with hypertension were unaware of the condition. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. International Society of Hypertension has released that 2020 Global Hypertension Practice Guideline. The inclusion of optimal and essential treatment paradigms attempts to address the issues that in resource poor city. Optimal care refer to evidence-based standard of care, whereas essential standard refer to minimum standards of care to allow a specification of essential standard of care for low resource setting. The AHA has released a scientific statement in 2021 offering new guidance for the management of stage 1 hypertension among patients with low CVD risk. Among all risk adult or 10 years CVD risk less than 10%. With stage 1 hypertension like blood pressure 130 to 139, 80, systolic is 130 to 139 and diastolic is 80 to 89 mmHg. Management start with non-pharmacologic therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacologic therapy. And third one is acute respiratory distress syndrome is a potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19. A recent study which appears in the Journal of the American College of Cardiology reports the metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. And fourth is lowering systolic blood pressure target down to the 110 to less than 130 mmHg range, substantially reduce severe adverse event in the STEP randomized trial, affirming that a sprint finding older Chinese population among some 8,500 patients ages 60 to 80 in China. The intensive target determines 26% of the composite CV risk finding from now a second major trial supporting a lower target could unite the guideline, which even among US professional societies ranges from threshold of the 130 to 150 mmHg. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European Guidelines of the Management of Arterial Hypertension recommend that the diagnosis of hypertension should not be only be dependent on the office BP measurement, but also on out of office measurement such as our home blood pressure monitoring, 24-hour and night time BP measurement were associated with greater risk of mortality and composite of CV outcome. Thus, they may be considered as the most relevant measurement for the estimated CV risk. For every 20 by 10 mmHg increment of BP measured at night, the risk of mortality increased by 23% and the risk of cardiovascular event by 36%. And most patients with hypertension required lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommended 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines equally recommended 5 classes of antihypertensive drugs, considering high non-adherence treatment and importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommended, especially in the context of lower BP target, to start antihypertensive therapy with the initial dual fixed dose combination of ACE1 or ARB and calcium channel blocker or diuretics. And since early July 2018, product containing valsartan have been recalled worldwide. The reason is the detection of a known carcinogen, namely N-nitrosomedimethylamine, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO, International Agency for Research on Cancer, to be carcinogenic in humans. If 1 lakh patients would have been received NDMA contaminated valsartan from Zhejiang, Hubei every day for 6 years in the highest dose, it could result in 22 additional liver cancer over the lifetime of this patient. The presence of NDMA in these drugs could be lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by significant increase in the rate of emergency department visit of plus 6%. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in the endpoints. The HYGEA chronotherapy trials tested whether nighttime therapy in a comparison to usual upon awakening hypertensive therapy exert a favorable CV risk reduction. The largest study included a total of 19,084 hypertensive. During an average follow-up 6.3 years, 1,752 participated experienced the primary CV outcome, and ambulatory BP management was performed for 48 hours to collect data and how BP different during sleep. The RR reduction of CV events was significantly improved for nighttime treatment compared with the awakening treatment. Okay, that's it.